to Ethics Grand Rounds from University of Colorado Hospital and the Anschutz Medical Campus, as well as the Center for Bioethics and Humanities. Thank you for joining us. And our topic today, which I'm very, very excited about, is ethical implications of ableism in healthcare. I'm very excited for multiple reasons. One has to do with our presenters, another with really the material that they're presenting and the very real issues among us, and things that we have been working to address here as well that you'll hear about. So first, I want to introduce Dr. Megan Morris. Dr. Morris is an associate professor of internal medicine. She's the founder and director of the Disability Equity Collaborative and is a faculty member at our Center for Bioethics and Humanities. Also, Reverend Dr. Annie Dondapati Allen, who is a staff chaplain at University of Colorado Hospital and Ethics Consultation Service lead. And third, Katie Herrmann, who is our Director of Social Work Services of UCHealth. So I am going to turn this over to them. I am, by the way, Reverend Julie Swaney. I am the co-chair of the University of Colorado Hospital Ethics Committee and part of the Ethics Grand Rounds team that brings these talks every month. Also want to remind you, please put your comments or your questions in the chat. We very much appreciate that. So with that, I'm going to turn it over to Dr. Morris.
Great. Thank you. There you go. Thank you. So I will be starting off our discussion today about the ethical implications of ableism in healthcare. So in our discussions of this talk, we decided to start with a case. We'll be starting with a case that's my case. This is my family's case. This here is a picture of my uncle David with my grandparents at David's high school graduation. David was born with an intellectual and developmental disability, or IDD, and what accompanied his IDD was pretty significant seizures that were difficult to manage with medications. But David was a very sociable guy. He lived with my grandparents through his adulthood. He loved walking the neighborhood. He knew all the neighborhood gossip, who had new flowers in their yard. He loved corny dad jokes and watching reruns of 1950s sitcoms, and he loved country music. But as David got older, he started having more seizures and was starting to have some pretty significant seizures that ended up with injuries. That landed in the hospital multiple times, and each time he would lose a little bit of functioning. And then as he was getting older, with this a little bit loss of functioning and my grandparents getting older, they were having difficulty keeping him safe during his seizures. So David ultimately moved into a nursing home in his late 40s. When he was 54 years old, so in 2016, he was admitted to the hospital from the nursing home with aspiration pneumonia. And I was living here in Colorado. My family's in Oregon, so it was December 23rd. And so I was actually home for the holidays and went with my parents to visit my uncle in the hospital. My grandparents, again, they were older. My grandfather was in his 90s, my grandmother in her late 80s. So they really relied on, particularly my dad and I, with managing David's care. And so David, again, aspiration pneumonia, and he was just incredibly weak. And with that weakness, he had difficulty swallowing. I'm a certified speech language pathologist, so I the team asked me to do a quick screen as well of his swallowing abilities, and he was unable to safely swallow. So the doctor put him on NPO. So over the weekend, this was a Friday, over the weekend, they gave him antibiotics, and at the start of the week, he was medically cleared. He recovered from the pneumonia, and the team was ready to discharge him back to the nursing home. But David was really weak still and was still unable to safely swallow. His swallow, I was checking it every day. It was continuing to improve, but it wasn't quite at the point where he could safely get all of his nutrition through oral means. And so the team looked to us of how we'd like to proceed, and we, considered different alternative nutrition routes, G-tube and G-tube. We thought the G-tube would be a bit much, but an NG tube would be a possibility. He had an NG tube before, and really had tolerated it really well. And we knew an NG tube wouldn't necessarily protect against future pneumonia, but it might buy him a few days to continue to get stronger, that he might be able to ultimately swallow on his own. And then this also was December 27th. So it was in between Christmas and New Year's, and David's typical team, his regular team, were all on vacation. And so we weren't able to check in with them to get their thoughts and opinions on David. And the team, so we said, we would like to just do a trial run of an NG tube and see, if we can give David a few more days. And the team pushed back, and they said that they thought an NG tube was too invasive, that it would be uncomfortable for David, and they didn't want to put him in any more discomfort. And so they recommended hospice. And we knew that David would ultimately have a reduced, length of life because of the devastating effects of the seizures on his body. But he had bounced back so many times from being so close to death, and even being on hospice before. And so we just didn't know if this was actually the end, or if he was going to bounce back, in a few days, in the next week. And so we sort of implored the doctors to, really, can we just do this, a few day trial of this NG2? We thought we reached an agreement, and then we went home. And then the next day, as we prepared to visit him, we found out he was discharged with a full diet. What had happened was that the team ended up reaching out to my grandparents and asking them if it was okay to discharge him on a full diet. My grandparents, who we don't know if they understood what was going on, they have pretty significant hearing loss, and so communicating on the phone is not a reliable means of communication, but they did agree. And so David was discharged with a full by mouth diet. And as expected, within a day, he developed pneumonia again. And so then the team came to us again and pressed for us to admit him to hospice. And this time, we thought about it, and we decided to agree. We didn't want David going back and forth, in and out of the hospital. That was just hard on him, emotionally and mentally, and physically. And so, yeah, we did agree to hospice. And then 2 days later, I sat with him for the very last time and provided oral care, as his lungs had just filled with mucus and secretions, and it was just pouring out his mouth. At first I thought he had vomited, but it was just the secretions just flowing out of him. So we provided him oral care, and hoped that his last moments were some level of comfort. And after this, my family and I had a really hard time. We and I still feel guilt about what happened. Had we advocated enough for David? That was our responsibility. Had we done that? Had we let David down? And so today we're going to be talking about ableism. And I really do believe that ableism really played an important factor in David's life throughout his life, outside of medicine, but also within healthcare, and at the end of his life. So before we start getting into that discussion, I just want to quickly go over some definitions and prevalence. So we'll be talking today about intellectual and developmental disabilities, or IDD. But a lot of what we're talking about could also extend to other types of disabilities as well. About 2% of the US population lives with an IDD, which is over 6.5 million people. Numerous studies have demonstrated that individuals with IDD have poor health and healthcare outcomes as compared to individuals without disabilities. And we see this across different chronic conditions, from arthritis, stroke, asthma, and then they're less likely to receive primary care services like pap smears and mammograms and dental checks. And in the most recent COVID-19 pandemic, we actually saw that a study came out looking at risk factors for mortality from COVID-19, and number one was age, but having an IDD was number two. Again, number two risk factor for mortality. So there's a whole host of environmental and social factors that really can influence the health and healthcare outcomes of individuals with disabilities, from decreased access to exercise opportunities, lack of accessible housing, decreased employment opportunities. But today we're really focused on disparities in quality and access to healthcare. But I do want to acknowledge again the factors outside of the healthcare system. So I mentioned ableism. Ableism, some people might not be aware or familiar with the concept, but it's similar to racism. It's discrimination and social prejudice against persons with disabilities in favor for those who are able-bodied. And we also have structural ableism, and these are the laws, policies, institutional practices, and entrenched norms that create and perpetuate ableism, again, in society, but in healthcare as well. Don't have a ton of time to go into all the literature about ableism. I want to point out two studies. One is by Dr. Eric Campbell, who is on our call today. Here at the University of Colorado, he developed and administered a survey to a national survey to physicians, and they found that physicians reported that 50% of them strongly welcomed patients with disabilities into their practice, and only 41% were very confident about providing the same quality of care to patients with disabilities as compared to those without. And 82% rated the quality of life for people with significant disabilities worse as compared to those without disabilities. I recently completed a study of CU medical students. We gave them the disability implicit association test and found that 85% of them had biases towards or preferences towards able-bodied, with 55% having the strongest level of bias. Only 5% reported feeling very confident about providing the same quality of care to patients with disabilities as compared to those without. And then 71% rated the quality of life of those with significant disabilities worse. And this last for both of these, the quality of life piece is really important. Literature actually shows that individuals with disabilities report actually similar levels of quality of life as those without disabilities. And I believe it's really important because assumptions about quality of life can really influence and affect decisions about people, about the care we provide. Really quickly, if you're not familiar, this is Michael Hickson. He was a man who had significant disabilities, was living in a nursing home, contracted COVID-19 at the beginning of the pandemic. In June, he was admitted to the hospital, and his team decided not to treat his COVID-19 related symptoms. And the wife actually, Michael Hickson's wife, recorded the conversation with the physician. And basically, the physician said he doesn't have a quality of life. And the wife said, why? Because he's paralyzed, with a brain injury. That's why he doesn't have a quality of life. And the physician said, correct. So I'm going to transition talking into the different ethical principles and how disability or ableism can affect and interact with these ethical principles. So first, some challenges with autonomy for individuals with intellectual and developmental disabilities. It is difficult to assess their ability to participate, definitely, consent, but also assent for medical treatments or even just discussions about their medical care. And it's very easy to make assumptions about someone's ability to participate. In my uncle's case, when we were during that last hospitalization, none of the medical team would ever speak directly to my uncle. They'd only talk, like stand over his bed, talk to us as the family, and then as the family would turn and talk to David. Many individuals with IDD have impaired communication, and there's lack of training on how to assess communication abilities and what tools and strategies are available at the bedside. Oftentimes with individuals with IDD, there are complex guardianship issues. For example, with our family, again, my dad was not technically the legal decision maker, my grandparents were, and it made it complicated for the team. For a non-maleficence, so in recommending treatments, it might require assessment of someone's quality of life. And like I said, we can easily underestimate someone's quality of life, which might result in under-treatment. It's difficult to assess pain of individuals with IDD if they have, again, difficulty with communicating. So it might result in either over or under medicating, or it might result in overuse of restraints or sedation. There can be, not everyone with IDD has behavioral issues, but it can happen. And this can be, overwhelming for the team if they don't have training on how to address behavioral issues or have other tools in their toolbox to address this. So again, it can result in the overuse of the restraints or even avoidance of a patient. So next is beneficence. So it's always a question of who determines what is best or what benefits the patient. Again, is it the family? Is it what role does the medical team in determining what is best? And for what I've also found for individuals with particularly IDD, it's can be hard for us to relate to what it would be like for an individual to have that type of disability. And so because of that, again, we have biases of, oh, I would never want to be unable to participate in, my favorite activities or, skiing, or I would be miserable if I couldn't have I couldn't play chess anymore. And so we make those assumptions and that can, again, influence the care that we provide. Can also lead to depersonalization. Then finally, ethical principle of justice. Like I said at the beginning, there's high rates of co-occurring medical conditions, and oftentimes individuals with IDD or other disabilities require extra services or accommodations. And whether implicitly or explicitly, there might be a reluctance to spend extra healthcare dollars to say, this is already a really expensive population. Haven't we spent enough on this? And so, a health system might not have the available accommodations available, or not provide, costly training to staff on how to use the accommodations or provide equitable care to these individuals. Right. I'm going to now transition to Annie.
Thank you so much, Dr. Morris. And I think that the case, just sharing your personal story and your experience with your uncle really anchors, the conversation that we'll have about the pathway. And I think, argues our case very strongly that we really do need a mechanism by which we can better serve our patients and our families and caregivers of those with intellectual and developmental disabilities. So my focus is going to be primarily on the pathway itself. And as Dr. Morris pointed out, the need for the pathway comes from recognizing that these gaps exist and that not much has been done in spite of our awareness of these gaps. And some of these encounters that we've had in the course of our work here at University Hospital have helped to identify not just the gaps, but that there are opportunities for some great collaborations as well. And out of that, we've tried to develop some best practices, and we just need to formalize what that would look like. In our effort to balance meeting the patient's medical needs with patient safety and staff safety, at least at University Hospital, we have code grays that are often the avenue that we rely on to de-escalate the situation and to keep everyone safe. Often these can be traumatizing themselves, to the patient, the family, the care providers, and especially to the care team. These patient encounters not only leave the care team feeling frustrated and ill-equipped to adequately care for the patient, but they often leave the team feeling morally distressed. And rest debriefs and one-to-one support sessions are often requested very, very frequently. So let's go to the pathway itself, and I will use a very brief example to talk about the pathway. If we could go to the next slide, please. So we have a, thank you. So we have a 30-year-old patient with a diagnosis of cerebral palsy. The patient is bedbound and with a tunneling sacral wound. The patient is transported from his home to University Hospital to the emergency department by paramedics. The patient's mother is quite worried that he may die en route, and so she rides with the patient in the ambulance. When they arrived in the ambulance bay, the patient's mother was told that the patient would need a 20-minute assessment and that she could not be in the room with him. After a while, when the mother asked security if she could be at the bedside, she was told by security that the patient was not in the system and that she was not allowed back. During this time, there were no updates that were given to the mother. She was not sure what was going on, and as you can imagine, was quite frantic about how the patient was doing. Eventually, the mother was able to come back to the room. By this time, the patient was delirious and crying for her. So let's look at the pathway. Our proposed pathway begins with the intake. When a patient with a known intellectual or developmental disability presents in the ED, the intake nurse would activate the pathway. Not all patients have been formally assessed or have a formal diagnosis. I'm keeping the conversation a little bit narrow and talking about patients that might have a known IDD, but there is another population where we may not know, and that's where the observation and assessment in person is going to come in handy. So once the pathway is activated, this would do two things. First, it would create an identifier in EPIC, similar to the one that you would see for a fetal loss, for example. every team member who accesses the chart is able to see the alert and to appropriately plan for how they would interact with the patient, how they would engage with the patient and with the family or the care provider. The intake staff will also have access to a virtual toolkit, which would include signage that they could put on the door, for example. Again, think along the lines of a hummingbird for end-of-life patients. It immediately helps us to know that perhaps I need to give some thought before I actually walk into the room. For example, you likely don't want to bring 5 people into the room with a patient while they're in the ED. The second thing that this does is that it immediately sends an alert to the ED social worker, the bed placement team, and the inpatient behavioral health clinical nurse specialist. And I'll come to that last part in just a moment. Patient placement would be alerted and they can make the determination, should the patient be admitted, about the most optimal placement for the patient. The ED social worker could start working with the family or the care provider and with the patient and continue to assess if there are emotional and sensory needs that we need to be aware of. And because there is a pathway with the necessary prompts, every person that is in the chart is following those prompts and is using that pathway. That way, every team member is able to see the information that's most relevant and pertinent to the care of the patient with IDD. The pathway and the prompts, in case you're concerned about the fact that it might be time intensive, because there are prompts with drop-down options, it is meant to not take up a lot of time and would really help us to capture all of the information that is necessary through conversation with the patient directly as much as possible, with the family member, and then the staff's observations as well. So just returning to the case, a simple thing that the intake nurse could have done or any of the staff could have done is to simply ask our patient, would you like your mother in the room with you? Or who would you like in the room with you? That would have helped them to assess if the patient is verbal, if they have any communication issues that we need to address, and then to really partner with the patient's mother to help inform the level at which the patient is able to communicate and their level of comprehension as well. Next slide, please. So let's go on to what happens when the patient transfers from the ED to the unit itself. The patient is assigned to a room with double occupancy and happened to be roomed with a patient with known behavioral issues and who had verbal outbursts throughout the night. The unit was aware of this issue already and it was documented in the chart. The patient has very limited fine motor skills due to their cerebral palsy, and they did not have a call button that was appropriate for their needs. In spite of the fact that video monitoring was discussed with the mother requested it, one was not available in the room when the patient got to the room. And so for that first night, the patient was unable to use the call button to alert the nurse that they were distressed with the verbal outbursts from the roommate. The staff were unaware that the patient was deeply distressed and did not really sleep that night because they did not have video monitoring that was available in the room. The patient was very frightened, and it was only the next day when the mom visited that he actually shared that with the mother. The patient was discharged with home health services a few days later, but was readmitted since home health services was not able to see the patient till 5 days after the discharge. So going again to our proposed pathway. As I mentioned, the pathway initiated at intake would send a consult to the inpatient behavioral health clinical nurse specialist. But the other piece of the pathway that I briefly talked about is bed placement, that would have been a really helpful tool at this point in assigning the room for the patient. The behavioral health CNS would place a consult in Epic to our occupational therapy team within the first 24 hours for a functional assessment. The OT team, we've had a great collaboration with Amanda Hoffman, who is their manager for the rehab services. And they have designated 2 occupational therapists who will be the leads for their team. They both have significant experience with patients with intellectual and developmental disabilities. Following their assessment, they will document their recommendation in Epic. And here are some of the options that they would then specifically put consults in for. Speech therapy, if there are any communication needs, the behavioral health evaluators that we have, they would be responsible for rounding on the patient and the caregiver multiple times a day. They would talk with the patient and the family and care provider to continue to make assessments about their sensory needs. They would then go to our supply room and get all of the sensory supplies that we have there. And keep in mind that this is an ongoing assessment. It's not a one-time thing. As they interact with the patient and the family and care provider, they continue to build relationship. So in conjunction with the recommendations from the occupational therapy lead, they will continue to do assessments themselves and continue to access all of the sensory supplies that the patient may need. Just a very quick list of things that we already have in our storage space, and we're quite proud of that because it's really difficult to find space, and really appreciate the collaboration with our teams to kind of find that space. We have weighted blankets, weighted vests. We will be having access to iPads, fidget toys, wave light projectors, vibrating sensory pillows, and many other products that we will continue to find and have those available in our supply closet. Music therapy, if that might be helpful for the patient, pet therapy, and our occupation therapy leads will be critical in helping us know what the sensory needs are, what emotional needs might be, and then request possibly consulting our chaplain team and our volunteer services as well. So just going back to our case very, very briefly, the alert in Epic would have helped the bed placement team to make the determination that rooming the patient with another patient with known behavioral outbursts might not have been optimal. It would have prompted the staff to partner with the patient and mom, and to inquire what other supports the patient might need. Do they need a call light? Does the call light that's available in the room meet the patient's needs? Do we need something different to ensure that video monitoring is available? For some reason, if there's a supply issue and we run into any glitches, then we have an opportunity to continue to talk with the patient and the care provider to be creative and think about what else we might do to ensure that the patient has all of the tools that they need to feel safe, to ask for support from the nursing team when they need it, and to also have the nursing team collaborate with the patient and the family to have eyes on the patient at all times, which is what the mother had requested. The fact that the patient was discharged and readmitted 2 days later, it's not uncommon. We do see patients coming back. The patient had a pretty severe wound. And because home health services was not able to see the patient until 5 days later, and the hope or the plan was that the mother would be able to provide wound care until then, which was simply not possible. The level of care that the patient needed was significantly greater than the mom was able to provide. And so because there was a little bit of a gap there, the patient readmitted and did successfully discharge after a few days with the appropriate home health services. So let's look at the stakeholders that we've been working with. If you're wondering how we organized the pathway, I'll say a little bit about the teams that we've been working with. So we have an education team. we have a toolkit team and a pathway development team. The toolkit team has already assembled quite a few supplies, and we will continue to add to that. We worked very, very closely with all of the stakeholders that you see here on the slide, with our nursing team, with our behavioral health evaluators, with our rehab team, with our behavioral health CNSs, to inquire about what would be the most helpful tools that we could provide for these patients. We're working very closely with our infection control team because all of the tools that are reusable needs to be appropriately cleaned and restocked. So Kelsey Smith, who is the lead for our infection control team, is partnering with us to come up with a tip sheet and will guide us through that process. The education team is headed by Wendy Berry, who is our behavioral health CNS, and she's developing education modules for all of our stakeholders. We're going to be doing some very targeted education with the teams that will be directly working with the patient consistently. And whenever the patient comes back to the hospital, because we all need the pathway has that trigger, it will immediately populate. And that way, because an assessment has already been done, we can go ahead and continue to add to that, but we have a great starting point to make sure that all of the sensory and the emotional needs are being met while the medical needs are being met as well. So Wendy Berry is working on those modules. We will work very closely with our code break team, our security partners, our BHEs, our nursing teams, and anyone else that might be interested or could benefit from this. The pathway development team is the one that's working on the pathway and trying to build that in Epic. Again, as I mentioned, this needs to be a very simple process so that it's not time intensive, and all of the teams that are utilizing the pathway are able to quickly input the information that then generates all of the information that we need to not only take care of the medical needs for the patient, but to ensure that the patient is safe, the patient is not unduly traumatized by the lack of resources and sensory tools. And as Dr. Morris talked about, we're really assessing the patient. We're honoring their autonomous choices, their wishes, their preferences. We're trying to benefit the patient. We're preventing harm for the patient and really focusing on justice for this patient population. I do want to make one very quick comment, and I'll hand off to Katie for the next segment. As Dr. Morris mentioned as well, our BIPOC communities, patients and families that we work with, there does tend to be mistrust in the healthcare system. And when we have patients that have intellectual and developmental disabilities, that mistrust might be heightened. This pathway ensures that all of our patients that might have an intellectual or developmental disability are receiving the same kind of care, but we're really providing compassionate, respectful care to the patient and partnering very, very closely with their families and care providers as well. I'll hand off to Katie for this next segment.
Thank you, Annie. I appreciate that. So in my section, I'm going to talk about the importance of, it's always important that discharge planning starts on the day of admission, but I cannot emphasize enough for patients living with intellectual disabilities when they come into the hospital. It is critical that we immediately, from the first minute they set sites in the ED, and if we know that they're going to need admitted, that we really prepare and start to gather the necessary information to help that patient if they do have to be admitted, because the hospital actually isn't the best place for these patients, and especially if they are admitted. Two of the cases that we talked about were cases where they had a medical need, but we also have a number of cases that do come through our ED where an IDD patient is living in a host home or living with mom and dad, brother or sister, and they bring them to the ED because they are unable to care for them any longer. And the hospital setting is not equipped to provide the necessary structure that these folks really require. And what we find, if we don't have a really good discharge planning from the start, these folks decline, and they decline fast because we don't have the structure or the expertise from our staffing to provide the best care for them. So when I came here about 4 years ago, I had a patient who, at the time I arrived, was here 9 months already. A patient who actually was one like Annie described earlier, that was not formally diagnosed with IDD, but had significant deficits. And we watched her decline over time. And one of the gaps that we had that was blaring is that we didn't really have any connections or really good relationships developed with the people in the community who could help us manage, care for, and transition this patient in particular, out back into the community in an environment that would best help her needs. And so quickly what we did is come together and work with our ED partners and say, when you have a patient coming in, communication is the key. You have a patient who is here, whether they're here because family is overwhelmed and cannot take them and it's not safe to discharge, or they have a medical condition. Our ED social workers immediately notify the manager of inpatient social work or the supervisor. Let them know through secure chat, usually through multiple channels, secure chat, email, telephone call, to say, hey, this is the patient, this is what's going on, want to alert you, they're going to be admitted on X floor. That manager then lets our social work know, and the ED social worker, as best they can, will collect the collateral information. And then what we've developed over the last few years is a really robust relationship in our state, what we call community center boards. And community center boards are the state funded boards that help families and persons living with IDD to live in group homes, live independently, and really function out in the community. Because again, it's least restrictive environment. And I can't emphasize enough and reiterate what Megan talked about is, checking our unconscious biases and sometimes conscious biases about what we think that patient is capable to do. A lot of times when we run into these folks, we say, oh, they need a long-term care setting, or they and maybe they do, but maybe they don't. And I think that's why it's really important very early in the discharge planning process that we reach out to family, loved ones, agencies within the community that can give us that collateral information, so we can really make a good determination about what is the best next step for this person. The other thing, once they're admitted, let me back up and just say, with our community agencies, I think sometimes we can have a back and forth of they're not doing their job, we're not doing ours. And we stop that. And, we're in this together, and at the core, the patient is what's important here. And we have monthly, quarterly meetings with those entities, the community centered boards, our regional centers, to talk about cases we've had, what were the gaps, what were missed opportunities, and how to improve, so it helps us inform. But when a patient is admitted to the inpatient, we immediately set up weekly meetings with the provider, the social work care management team, chaplain services. If there is a behavioral health need, there isn't always, but it does come up, that we have everybody, family members, participate, and we talk about, okay, Joe is here now. What do we need to do to limit the stay for Joe? Because we don't want Joe to continue to decompensate. And that's where we use the pathway that Annie talked about. It is the little things. It's what kind of music do you like? Sometimes we have also in our hospital, we have an area down at the end of the hall that has a beautiful sitting area for family with windows. And sometimes we have those patients that they're just nervous and they need to move about, and being in that small room can be really confining. And so we will move them to the end of the hall so that they can actually have a little more space to calm down and self-regulate. I think consistency with the staff, really making sure we're paying attention to that. But we set up these weekly meetings with our stakeholders in order to some degree to hold people's feet to the fire, to say, no, he can't and should not stay here ready for discharge for 4 more months until you find an ideal placement. You know, we need to help get this patient to where they can thrive and succeed in the community. And as you can imagine, being in the hospital without an intellectual disability can be very frightening, but for them, it's even more so. So it's really, really important that we pay attention to that throughout the discharge process. And then we help to get those patients out as quickly as possible. So I think communication is the key. Recognizing more than ever, discharge planning starts at the day of admission and continues throughout this process to get them as quickly as we can back to their community. And so that's our best practices, and really hooking up with those community members, embrace them and work with them and meet with them to talk about what we could do next time, because every case is different. And I'm going to turn it back over to Megan. And thank you so much.
Thank you, Katie. I have a few slides at the end about some steps you can take today to kind of work towards anti-ableism in your work life, but also your life outside of work. But I'll go very quickly so we make sure we have time to have questions at the end. So the first is to acknowledge and name ableism. Include ableism and in persons with disabilities in your equity efforts. 2, pay attention to language. There's person first and there's identity first language. Using value neutral language, that we're not really imposing our beliefs of what it's like to be someone with a disability onto that by the language we're using. Really important for people with IDD is using simple but age-appropriate language. Using baby talk can be condescending to many adults with IDD. Document patients' disability status in the EHR. As of January 3rd, it is a policy at UCHealth to be documenting patients' disability status in the demographic area of a patient's record. This should be documented as a part of registration, intake, scheduling, etc. Provide accommodations. There's a wide variety of different accommodations. Annie talked about some that are available, but make sure that they are you have these available in your clinic, your unit. And then also think about just, again, your policy, flexible rooming policies. Again, as Katie was mentioning, putting someone in a different room that gives them a little bit more space. These things can make a world of difference for these families. Educate yourself at work, disability competency training, learning where the accommodations live and how to use them, how to also clean them too. And then beyond work, work to understand the historical context and systemic ableism that is really perpetuated inequities today in our health system, but also, again, our society. I like to throw up the Crip Camp, which is a great documentary on Netflix. And then if you also have if you're a UCHealth employee and you have questions about accommodating patients with IDD or any other type of disabilities, you also have an ADA coordinator, Cherish Ross, who is also available to help you talk through accommodations. All right, and with that, we will open it up for questions. Thank you.
Okay, thank you very much. a number of comments and questions. And thank you all. One person is asking, it seems typical for an IDD patient to refuse services after physician orders have been placed. Can you please talk about the correct protocol for assisting these patients that need a service but are non-compliant? And I guess I'll first give that to you, Megan.
I think the question is understanding why. Why are they not open to those services? So when I do a lot of research around the ADA and in healthcare. So you also need to think about, okay, what is the medical care that we need to be providing the patient, but what are the accommodations or the assistance that we should be providing a patient to ensure equitable care? And that is actually legally mandated by the Affordable Care Act and the Americans with Disabilities Act. And so you need to think through, we've had patients who say, well, I don't want that accommodation, but asking them, well, what accommodation would actually help you participate in your care, would help this be better? So having those conversations with them, and if the patient refuses a service, that is also their right, and we need to respect that and respect their autonomy.
Just a couple of thoughts that I would add to that. I've been here about 10 years now, just short of 10 years, and I've worked with a lot of patients and families around, patients with intellectual developmental delays, some diagnosed, others not. And when a patient the team is wanting to have a procedure done or a blood draw, whatever that looks like, I can tell you that when I have to have a blood draw, I am not going to be the happiest person on a good day. And I just imagine it is one of the things that ideally we would have a low sensory room. We would have a space that actually is not overwhelming for the patient. We have schedules that we have to keep. There are certain things that have to happen at certain times. And for a patient with an intellectual or developmental disability, that is overwhelming. And I would, as Dr. Morris pointed out, I think some reframing is really helpful. I would say that compliance is something that the patient likely won't understand. And for the family, that may feel kind of either offensive or it can put them on the defensive. So really trying to understand what are the patient's triggers. Some patients do really well with getting a blood draw, others don't. Some patients do better when their family member or care provider is in the room with them. Some do really well if they have some kind of a sensory object in their hand, or maybe some music that's playing. That's where the pathway comes in helpful, right? We're asking these questions and it'll continue to populate in the patient's chart so that when there is a necessary intervention that needs to be done, the provider then is doing the heavy lifting. You're looking in the chart, you have all of these great recommendations, plan your time, meet with the patient, build that relationship. When you walk in, they may still be in a really bad space, but it is a process. And patients, even without a diagnosis of IDD, are likely to have some challenges with that. I'll give you a very quick example with the case that I shared. The patient had a 4-hour MRI that had been put in Epic. And the MRI tech just instinctively knew and trust their nursing instincts and said, with the patient's not being able to kind of lay still for 4 hours, they asked if there was any way that they could try and do this in an hour and a half, maybe do it in 2 different segments. It turned out to be a 3-hour process anyways, but it's going to take those kinds of accommodations. And again, just kind of reframing it that maybe they're not being non-compliant. They might be anxious, they might be fearful, they might be needing some additional supports, not just accommodation, but additional supports in place to successfully go through, have that intervention done.
Thank you. So both Katie and Megan, a comment and a question. Megan's family wanted their uncle to stay. Katie talked about discharge. How do you square these efforts?
Well, I'll start by saying, remember, medically ready to go. I think that's a key thing. If someone is here for placement because it's not a safe discharge, but there's no medical need for them to be here in acute setting, that's when we need to focus on helping, working with our outside community providers to get them back out to their host home or to the community. I also think a key thing here is listen to the family. I think often we make some real assumptions about the family. Either they dump them here or they're too involved and you know, what's wrong with them? You know, we need to stop and take a breath and check our unconscious biases and listen to the family who, especially in Megan's case, it was very clear that they knew their family member and they knew what had worked in the past and what hadn't. And I think it sometimes we dismiss when we really should listen. That's just my opinion.
Thank you. Okay, another comment and a couple of questions that go with it, and I'll try to summarize, but basically for people who tend to be fairly high functioning, but under the stress of being sick or being admitted to the hospital, are not functioning as well. And the concern is putting a flag in the chart to this effect in terms of something related to IDD. Is it possible that it may make situations worse, that staff will begin to other the patient when they see that flag?
I can take this one. So I have spent the last decade studying the question around documentation. And yes, this is always a concern with other types of disabilities like hearing loss. Well, you're putting something in my chart that shows that I have this disability. And yes, we know that there is discrimination, but we've done lots of studies with individuals, asking them, we've done surveys and qualitative work, and actually people with disabilities, the vast majority are actually, no, I want that information in my chart. I want my medical team to know this about me. They collect a lot of other really personal information. This actually isn't, that personal. And then the other side is, we can't start measuring and addressing ableism unless we know who has a disability, because some people say, oh yeah, I don't want to, you don't want to document it, but they might display characteristics of, like, for example, someone with a hearing loss. Well, maybe they're not hearing, and so they're not responding correctly. So people make assumptions that they have cognitive disability, and then they start treating them differently. And so just because it's not in the note doesn't mean that discrimination isn't going to happen. And what we need to do is actually train our teams to be, to recognize, again, our unconscious and conscious biases, and be able to see that in note and then be able to respond and provide patient-centered care.
Thank you. So another comment, I'm curious about folks who might show up without a formal diagnosis, but identify as disabled or are identified by family members. Is the diagnosis the inclusion or an exclusion criteria?
I think Katie kind of touched on this briefly about we do get a fair number of patients that have never been formally assessed. I can think of a patient who was deaf, mute, was a refugee, was in her mid-20s, and the family could no longer take care of her. And so they brought her to the hospital, and we worked very hard to find the appropriate support for that patient. That patient had never been diagnosed, but clearly there was a developmental delay, but that collateral information we were able to get from the patient's family. It's also possible that they have a diagnosis, but they haven't been assessed in quite a while. And this is an ongoing process. Just because you have a diagnosis that was done at 5 or 10 years of age, we really want to, in an ideal world, we're able to provide some of that assessment here in the hospital. And I think our occupational therapy colleagues are going to be critical in that, to do some of that functional assessment, have very clear recommendations. And as hopefully as this effort continues, we're able to provide some other types of assessments as well to more appropriately support them.
And Annie, I would just add that that's the other crucial piece why we need to embrace our partners out in the community. In that case that Annie referenced, I was able to leverage and go to our Department of Psychiatry, and one of their psychiatrists or psychologists actually was able to do the testing on this young woman. And that's the first thing that they needed for us to set her up with services in the community. And we were able to do that. It really does take a village. So that's really why it's important for embracing the other partners.
Thank you. And I think that the, even though someone hasn't been diagnosed, if they want to access the pathway, yes, would be the answer here. For somebody to be able to get what they need. Many more questions and thoughts and comments. Thank you, everyone. I do want to really thank Megan Morris, Annie Allen, and Katie Herrmann. Thank you very, very much for your ongoing work in this and for sharing that with us. And wanted to call your attention to Dr. Morris's wonderful article about this in the New England Journal of Medicine recently. The link is in the chat, and it's a wonderful article. And thank you for sharing all of this with us as well, Megan. Really appreciate that. Want to call your attention to a month from now, March 9th, will be ethical issues in blood shortages. So that will be our next ethics grand rounds, and hope you can join us. But again, thank you, Megan, Annie, and Katie. Really appreciate it. Bye-bye.